Hi, everyone. Thank you so much for joining us tonight. My name is Carmen David. I am an aortic dissection survivor, and I'm an aortic athlete.
And I'm Jack Crow. I'm also an aortic dissection survivor, and I'm also an aortic athlete. Carmen, how you doing?
I'm doing good.
I
I'm busy with
heard.
my kids for the summertime, though.
I hear you, and I hear you're also busy later in the summer because you've got your annual Run for the Heart 5K and 10K coming up. Is that right?
Yes, that's on August 23rd. So over many years and with the support of many runners and donors, we have raised over $150,000 for aortic research and related studies, which includes the exercise studies. You can find details. It's actually called runforaortichealth.com. And it's a 5K and 10K. So we'll put that link in the show notes so that people can sign up and participate, which you can do in person in Fort Worth, Texas, or virtually, which includes international participants. So we hope you guys join us. But Jack, you have some other news for us too.
Well, my news is less exciting. I'm an old man. I'm turning 65, and I've decided I'm running my last marathon. But I'm going to go out in style in November, uh, and I'm going to be co-captain. Get that, of Team Ritter, and so I'll be raising money for the John Ritter Foundation, and looking forward to one more being kicked by a mule. So Carmen, what's our topic tonight?
So tonight our topic is on the 2025 updated statement on aortic disease, competitive athletes and exercise, which was issued recently by the American College of Cardiology and the American Heart Association. So we are very honored tonight to have two leading cardiologists and friends of aortic athletes with us who were involved in putting that statement together. Dr. Alan Braverman is a professor of cardiovascular diseases and head of the Marfan Syndrome and Aortopathy Center at Washington University Medicine in St. Louis. And Dr. Timothy Churchill is a cardiologist at Massachusetts General Hospital and assistant professor at Harvard Medical School.
Yeah, and we start every interview with a reminder that tonight's discussion is for educational purposes only. No one should rely on this discussion for medical advice. Got that?
Yeah, and that's because all of us are different in where our aortic disease. Everyone's different, so it's important that people run their exercise plans through their cardiologist to find what's safest for them.
And please click on like, join Aortic Hope, subscribe to this channel. Join us on Facebook, Aortic Athletes. Join Aortic Hope on Facebook as well. There's a really powerful community of people, and you don't have to be alone. So, Dr. Braverman, Dr. Churchill, welcome. I thought we'd start off tonight with giving the stage to you guys to introduce this topic about the 2025, I don't know if we're calling them guidelines or not. Maybe we're not. Maybe they're, I mean, that might be part of the conversation, I have a feeling, on competitive athletics and exercise and aortic disease. So, Alan, let's start. Dr. Braverman, let's start with you.
Hey, how about even before we start, I'll just say hello, and Tim, you should say hello. Tim, why don't you say hello and introduce yourself, and then I'll talk for a little bit while we pull up these slides. Somebody has them on your end.
Yeah, thanks so much. It's nice to, it's really a pleasure to be here. My name is Tim Churchill. I'm a cardiologist, like Carmen mentioned, at Massachusetts General Hospital in Boston. And I spend most of my time focused on cardiovascular disease in active populations and athletes, and with a particular clinical and research interest in aortic disease. So this is a topic near and dear to my heart, something that I sort of like to spend, that I spend a lot of time thinking about, researching, and working with patients clinically. So it's a real pleasure to be here, work with this group.
Thanks, Tim. And I'm Alan Braverman. And unlike Jack, I am not an old man. I'm only 64. So I got a long time before I turn old. And with full disclosure, I have never run a marathon, but I watched my youngest daughter run the New York Marathon when she was in law school at NYU. So we witnessed that incredible feat, and I have nothing but awe for all of you that do endurance athletics, especially marathon training, triathlons, and these sort of endurance. So congratulations. So can I have the slides on? Jack or Carmen, one of you asked, is this a guideline or what? It's actually not a guideline. It's a scientific statement. And that's different than the last iteration where there were very specific sort of recommendations as a guideline does. These are really more statements of, and much more nuanced. And as you will we'll talk about, a lot of gray zones as opposed to sharp cut points. Although in someone who's written a few guidelines now over the years, unfortunately, in order to write a guideline that's helpful to our community, those who look and read and things like that, we have to use numbers. And with every number, there's a point, a decimal point, and then so something a little bigger or a little smaller is not in that line. And that's really not the way the world works, and that's not the way physiology works, and that's not the way medicine works. So there's a lot of give and take about how we do things, but we have to put specific numbers down, just like ages. Age 65, Jack defined as old. Age 64 would be young because it's not old. So obviously there's a grade there. So the same thing goes with aortic size and weights and all these sort of things. There's a lot of nuance. And I think in a broad stroke, the beautiful document that Tim helped our group organize, and he was the lead author on the group that we worked on, is really one of gray zones and how to enable an athlete to participate using all the information possible. And the document, again, specifically deals with competition, meaning you're doing your absolute hardest, your zenith to compete, to win, as opposed to you and Carmen, who are doing recreational endurance exercise because it's fun and you like the challenge, as opposed to saying you're going to go to your absolute max at the highest level you possibly can, which is the definition of competition, trying to win at the highest level. So those are differences there. This document doesn't address the recreational aspect, which is very important because that's what most of the people on this call are interested in. Okay, Josh, I don't know, or anyone able to pull up the slides? If not, I can see if I can open them on my end and read them off. But there's some.
Dr. Churchill, I think, had them up earlier. Can you?
Oh no, sorry, those were my slides. I didn't have them.
If not, I mean, if you don't, I sent them by an email, I think, to
Joshua.
You guys.
Joshua, do you have them?
Sure, I can open it.
If you don't, the word I can kind of read off them and talk. They're not so critical. So let me just do that. If you open them up, that's fine. The first one really is just a document. The second one, the second slide, which you can't see, there's several sections on here. Section 7 is Task Force 7, and that deals with aortopathy, which for the purposes of that include bicuspid valve with valvular disease and the aortic disease that can go along with bicuspid valve. And then we included spontaneous coronary dissection, which is not an aortopathy, but a primary abnormality of the coronary artery. And then I listed Tim as our lead. And then really we had some of the world's experts in sports cardiology on this. Dermot Phelan, Flavio De Sanzi from Italy, Aaron Bagish, well known to this group, Tim's former partner, and then Jonathan Kim, the lead author of the whole document. And then I am not a sports cardiologist by training, but I am an aortopathy specialist, and that's my area of expertise, especially genetic aortopathy. So they brought me in to try to keep these guys in line with that aspect of care. And so specifically, when we thought about, what does this encompass? First, how to keep the competitive athlete safe when an aortic condition is recognized, and what defines an aortic condition. And Jack, and some of the questions that you asked about, you said, well, what's the purpose? Is really to prevent an acute aortic syndrome, an aortic dissection, or an aortic rupture, which are thankfully exceedingly rare amongst young competitive athletes. When you think of the world of sudden cardiac death, not necessarily sudden cardiac arrest that's resuscitated, because that's an arrhythmic event, but sudden cardiac death related to exercise or competition, in particular competition. Aortic dissection represents a very small fraction of that very uncommon problem. And you say, well, why is that? Well, first, aortic dissection is uncommon in the general population. First of all, it's a condition that affects people 60 to 70 years old in general, type A, maybe 50 to 60, type B, 60 to 70, male predominant. But when you look at the world of young people with aortic dissection, and young in that realm is defined as less than 40 years old, it's a fraction of that. So maybe 3 to 15 per 100,000 people experience an aortic dissection. Only 7% of dissections occur in people under the age of 40, and 2/3 to 3/4 of those have recognizable conditions, like a family history or a connective tissue disease like Marfan. So if you think, well, how often do we see a very young person in his or her 20s with an acute dissection related to exercise that doesn't recognize they have a risk? It's not very common. So again, saving a life from that is really recognizing an underlying condition and then giving advice. Okay, so moving on to what we wrote about, there's some general tenets that we talk about when we think, how do you evaluate people who might be at risk? So first, if somebody's known to have an aortic abnormality, an enlarged aorta, for instance, an aneurysm, a bicuspid valve with enlargement, you want to make sure you get a good picture of the aorta, a comprehensive evaluation, which may include a CT or an MRI in addition to an echo. And then the decision making that we use for athletes depends on what's the size. So we have to make a very careful measurement of the aorta. Many times errors are made in how do you make that? And then when we follow the person over time, we compare images side to side. We don't rely on somebody else's measurement because that's often where errors are made. The measurement's a couple millimeters bigger when it was just measured differently than before. And then we follow the aorta over time at regular intervals, depending upon the size of the aorta and other features, but generally yearly, sometimes 6 months to 12 months, again, depending upon the situation. And then how do we define an aorta that's bigger than normal? When does abnormal become into play? And then how do you evaluate somebody who has that? Because we want to know what's the underlying condition so we can give the best advice possible about what to do in competitive athletes, let alone recreational. So we always want to evaluate, is it a heritable condition? We call those heritable thoracic aortic diseases, or HTADs, because if you have one of those, the specific gene that's present and the variant in that gene and the family history and the aortic size and other features all inform how it's managed and the aortic risk. So that's defined by a certain size of the aorta, what the family history is, or other clinical features that suggest an underlying condition like Marfan and others. So after a careful evaluation of somebody, where we've done a careful multi-generational family history, does anybody else in the family have an aortic event, a dissection, unexplained sudden death, a cerebral aneurysm, things like that? Has gene testing been done? Is it negative? Has the family been screened for others with aortic enlargement? Because sometimes other family members will have a dilated aorta or an aortic event. So then we know it's familial. And in situations like that, where all that testing's negative, then we put up our hands and say, we have not defined why your aorta is bigger than normal, so it's unexplained. So again, that's still a condition, and the risks are less certain when we have that. So that's kind of the background about it. I'll stop then and let Tim take over with some initial discussions about some of the things we talked about, perhaps bicuspids, heritable disease. I'm happy to talk about that in the Masters athlete.
Great. All right. Give me 1 second. All right. Seeing this correctly, I think, hopefully. So I'm just going to jump in there and I think just to kind of go through some of the specifics of what we included in this. And, I think I'll start with, just to echo what Alan had said, just to kind of highlight a few of the basic principles. I think number one, that a concept that permeated the whole document and including the section on the aortic, which is really, and this really represents one of the biggest shifts from in the whole field of medicine, cardiology as a whole, and specifically as it relates to sports and exercise, is really the embrace of the concept of shared decision making, which is a model of decision making that's really where the physician or other clinician is really partnering with the patient and as well as other stakeholders. In some cases, that includes team physicians, trainers, others, we're really partnering together as opposed to the sort of paternalistic model of prior generations where we were essentially the physician was sitting there on high, making a decision for the patient. So that's really something that's really become a center point for the way that we think about this decision making. It's not myself or Alan making a decision for the patient. It's us partnering with them to try to make the best decision possible. So Alan mentioned the importance of careful imaging. Just to highlight, there's a lot, I think, in the world of aortic disease, there's a lot of different ways to think about aortic size, and we sort of acknowledge, and I think we view this document, this is not a replacement for the general guidelines on aortic disease, which were published in 2022, and are a document of 100 some odd pages with exquisite detail on many areas, and I think including all the different ways of thinking about aortic size. But in the context of our effort, we focus primarily on the absolute aortic dimensions rather than body size indexing, height indexing, aortic length, and sort of all these others. Really putting the absolute dimensions as the primary decision maker, and acknowledging that when we get to the significant extremes of body size with larger or smaller athletes, that we do need to think about body size or other forms of indexing. But in most cases, we're really focused on the absolute aortic dimensions. And then I think just lastly, to highlight a point Alan made, which is that calling something unexplained necessitates that it's unexplained after careful evaluation. So that includes testing the family, looking at genetics in many cases, and otherwise not just that the person comes in and they say, I don't know why my aorta is big. So just to kind of get in the weeds on a few of the specific topics. So we segmented our the primary focus of the document was, and the focus of our section was on the aortic disease in the young competitive athlete, which in this case was defined as up to 35 years old. There's a separate section which specifically addressed considerations in the master's athlete, which in this case was defined as over 35, which I'll touch on briefly in the end. But in the younger population, we divided our piece into an area focusing on bicuspid valve associated aortic disease, and then hereditary thoracic aortic disease, so a collection of different genetic or syndromic causes, and then what we labeled unexplained thoracic aortic dilation. So in the bicuspid aortic valve, this is an area where we do have perhaps more data than in some other areas. And so what we ultimately did was we segmented the population here by, as Alan mentioned, we acknowledging all of the gray, we had to put some degree of numbers to make this a clinically useful document. And so we put a dividing point based on what the most recent general aortic guidelines defined as an aneurysm versus dilation. And so specifically 4.5 centimeters or above. And we used that as our threshold for thinking about the risk profile. And I think what the thinking that went into this really reflected was that the risk of events, and specifically these acute aortic syndromes, as Alan mentioned, is, and there are data to find this, is really quite low among bicuspid valves in the size range below 45 millimeters. And then we have seen an inflection, a higher risk above that. And so we felt that there was correspondingly a different risk associated with sport participation in that context. We wanted to leave some room for extenuating circumstance and not make it a completely rigid document. So we do include caveats specifically saying that there are exceptions to every rule, and that after a careful evaluation with this shared decision making, and then also emphasizing the role of meeting with experts like Alan, other sports cardiologists and others, to really have a comprehensive multidisciplinary assessment. Then the last point I think which we made here, which is echoed elsewhere in the document, is really that athletes who are meeting what would be established surgical thresholds or at least thresholds for consideration of surgical intervention, generally shouldn't be participating in what we considered competitive athletics. And then this is, again, this is competition, as Alan mentioned, competition for specifically, really, this is really designed, framed around peak effort, people trying to really on exercising, competing, or participating with real, true competitive goals to try to win. This is not, I'm going and doing light exercise for health. This is the people who are going out and exercising in England to win. We then, from there, from the bicuspids, and I'll mention that there was a separate section elsewhere in the document specifically focused on bicuspid valve associated valvular dysfunctions, stenosis or regurgitation. So that was not part of the charge here. But from here, we next turn to the hereditary thoracic aortic disease, and this is the group of conditions that have a genetic or a syndromic diagnosis. And the challenge here is that there are a lot of them. There's a lot of disease-specific nuance, gene-specific nuance, and we ultimately determined that prescribing specific sport participation guidance for each specific disease was not a realistic goal in the context of a relatively brief document like this. So the things that we emphasized were, again, consultation with really content topic-specific experts like Alan. I think the concept that the HTAD as a group generally are viewed as being a higher risk profile than certainly than the bicuspid, or also than the next group that we'll review. And that competitive sport participation in this group, when there's significant aortic dilation, is viewed as a higher risk profile. So, and it needs to be treated and evaluated accordingly. So that's where our thresholds and our sort of considerations for sport participation were generally were a little less permissive in this group than in the group and then in the other two groups that we discussed. Finally, the last group, as we've mentioned before, is what we labeled the unexplained thoracic aortic dilation. And here I think this is where there's a little bit more uncertainty and a little bit more nuance as to the specifics of the risk profile. I think the point that we wanted to make here was really that this is an area where we don't ultimately know the risk profile. We think that in some cases these are individuals where there may be, even if they've had a negative genetic evaluation, there's a possibility that they might be what we would consider gene elusive, which is a genetic cause that hasn't yet been defined. And so I think we led with acknowledging the uncertainty and acknowledging that this may be a phenotype or kind of a type of aortic condition where there may perhaps be an intermediate risk profile compared to the bicuspid and the HTAD group. And so what we tried to do was provide a little bit more nuance here with, in this case, is with numbers that were slightly, when compared to the numbers we applied to the bicuspids, slightly less permissive and slightly more sort of acknowledging the uncertainty and the possibility of greater risk here. And then while also, again, allowing the possibility for individualization and real shared decision-making between the clinician and the patient.
And that was a great summary. I'd like to just add one point. So, thinking, over a career of seeing people with big aortas or with unexplained aortic dissection, for instance, we would do a set of genetic testing 15, 20 years ago, and we could test one or two genes that were known then. And now we have a panel of certainly 12 genes with really good data, and maybe 20 on the panel with less stringent data. In other words, so the document emphasizes the importance of awareness when an aorta is bigger than it should be and not explained by body stature or participation in sports when you're young being, again, 25 to 35. We just don't see the big aortas in those people, even with sport. in large populations, just very unusual. So it sets the stage for what is it, and stay tuned. We may have new gene availability down the road with new discovery, with whole exome sequencing, with whole genomic sequencing for families, and find out more about families. I think we should move on then just to talk to this group, many of whom are like Jack or masters, and to say, the aorta is different. You've identified it. Your group has been, a leader in this area, identifying, what may be happening to athletes that participate in endurance or, high levels of intense resistance training for decades, and then, get to be 65 years old. What does the aorta look like? And then how do we think about that differently certainly in competition, because it's certainly more lenient in the document, as it should be. And there are different groups, even though the aortic size is different.
Yeah, I think I'll touch on this briefly. Thanks, Alan, and then we can probably turn to some questions. But I think this was the first time that this document has specifically included a section about masters athletes. And I think this is good because the field in general has really learned about the cumulative effects of lifetime exposure to exercise or training and the different sort of both positive and negative cardiovascular effects that are seen in that context. So this is something, as Alan mentioned, that we've sort of spent a lot of time looking at, thinking about, and I think with the kind of the real key takeaway from some studies that we've done, as well as others in the field, that mild to moderate aortic dilation in the long-term masters athlete is enriched and appears more common than in the general population. And what this has raised as a possibility, and I labeled it thus because I would argue that it's not definitively proven or anything, is that there may be an exercise adaptation over time in terms of enlargement of the aorta. And so I think what this is, and this is coupled with the fact, I think, with the greater prevalence of high blood pressure in this population of 50, 60, 70-year-olds, as well as the natural growth of the aorta that we tend to see with age in general. So with all of that, aortic dilation to a mild to moderate degree is actually becomes relatively common when we look at different populations of masters athletes. And so I think while highlighting some importance of kind of the basics of aortic care, we tried to frame this group as a group that is different and fundamentally different than the 23-year-old with a big aorta. Whereas we have in the 23-year-old, we have large data sets that say that is not normal. In some of the population, some of the studies in the masters population, we have rates of up to 20% of aortic dilation that falls into the mildly enlarged range. So with that in mind, we tried to frame this as a different consideration or concern, allowing a bit of a more tolerant, more permissive approach towards endurance sport, emphasizing again the role of thinking about kind of partnering with the patient and shared decision making towards sport participation when athletes were getting up into the larger ranges, into the aneurysmal range, and then again finally with the same general approach about competition once people reach surgical thresholds that we were generally recommending against competition for those individuals. I think that's kind of covers what I had specifically wanted to talk about. Perhaps, Jack, I'll pause. Jack, Carmen, I can unshare and then we can take some questions with that.
Yeah, that sounds good. Well, I'll jump in here with the first question then, since you were just discussing the joint decision making. He's saying that one of the major changes is since the last revision of guidelines is a focus on that joint decision making. So can you just explain again, like why the change and why should athletes be more actively involved in making those decisions with their doctors than just merely taking their advice at an appointment? Are we going to end up with more gray zones around exercise with that joint decision making as well?
It's a great question. I'm happy to comment, and I'll let Alan chime in as well. I think the emergence of shared decision making is something that has come and from really recognizing that patients really are not only are their own advocates, but also they know themselves. They know their values, and they can think about how they can integrate risk, integrate uncertainty into really making the best decision for them. And I think what this reflects is that sports, exercise play different roles for everybody. And it's difficult for me as a clinician when I meet someone for an hour to really have a good understanding of it. I think there are people for whom we've seen over the years the mental and physical effects of exercise or sport restriction can be devastating. And with anything in medicine, it's incumbent on us to really think about not only the sort of the potential benefits in this case of that if we thought that sport restriction would be reducing aortic risk, but also the potential costs of any decision. And so I think that's really where the idea of partnering with the patient, because the idea that I as the physician would know better than they would about their values, their risk tolerance, their goals is just, I think, is not a fair reflection of, that doesn't reflect reality.
Yeah, and I think that's something that, we try to tell people too, because there are a lot of questions around, well, I've done, marathons in the past, or I've done this, and now I have all these restrictions. And even the demeanor, there's some people are more assertive than others in an appointment to be able to ask these kinds of questions. So we want to encourage them to be able to, you are a team, you want to be able to ask these questions and, press your doctor, because some of these doctors are not all on board or educated to even answer this maybe for their patients.
I think that's a very important part. I think the default answer by many clinicians who probably are just not informed is to be restrictive. It's a safer approach, but it's really not appropriate for many circumstances. So this whole world has changed over the last decade or so, and particularly the last 4 or 5 years, and I think for the better. So I think there's a lot of frustration. I see lots of people for second and third opinions. I'm sure, Tim, that's your whole clinic, because someone has said, an answer that was not satisfactory to somebody who's very interested in running a marathon after an aortic dissection. In other words, that wouldn't be the first thing I would tell somebody to do after an aortic dissection, but people want to do that. Carmen and Jack, you're living examples of that. That wouldn't be the usual. I mean, you guys know that, and the people on the call know that. But you're doing it with success, but you're also doing it with some guidance and recognition and close follow-up that your blood pressure is good, that your aortic health is safe. And, it's really codifying what the experience is under, as careful control that you can have that will enable us to say, in 5 years, look what we've gathered. We did the same thing when we looked at bicuspid aneurysms that were removed with a graft, and then people did, Ironman and ultra marathons and things like that. People like Tim and Dermot and Aaron were telling their patients, I think it's safe. And then we just wanted to answer the question, is that safe? Because patients were asking me, and we said, well, let's find out. And obviously it was safe, but because that's what the data are. But you say, well, what about if you have Marfan syndrome or something like that? We have no data. We know that those people have recurrent aortic dissections, have distal aneurysms. It's a different group. So you have to be careful, and you have to use the data best you can. And so I think, what I would say to all aortic athletes that are on the call, and I think your cohort already knows this, ask the question, find out from a knowledgeable, careful physician. If you can see a sports cardiologist, good for you. They can be hard to find because they're not in every town. Obviously, you have to go to a specialty center. But get involved. Try to take the information to your clinician and say, this is what I've learned, and work with me. So rather than say what I can't do, I say, let's see what you want to do. How can we make you successful doing what you want to do within reason? sometimes a person will say, I'm going to find the doctor that lets me do what I say I want to do, when it really doesn't make sense. But that's not the answer either, of course. We really want to give the best advice we can so they're safe, and both of us sleep at night knowing that it's really a good plan.
Yeah, I
Well,
think we do try to tell people, like, it's not, second opinions like that, like you said, aren't for looking for that yes or the go ahead approval, but just to let the next doctor, if one doctor is not understanding your active lifestyle and it is affecting your mental health drastically after such a diagnosis, then a second opinion is warranted to try to just have a team, you and the doctor, that do understand what your goals are. So there is a difference, like you said, it's not shopping for the approval.
Yeah.
A couple months ago, Carmen and I interviewed a guy named Torbjorn Sindball. He
Yeah.
was a professional Ironman triathlete. And it turned out he and I actually competed at Wisconsin Ironman. Well, I participated. He competed at Ironman Wisconsin years ago. He finished in about 6 hours. I finished in 12 or 13, or at least before midnight. But he had an incidental finding of a dilation during his career. He continued to participate after, checking with at the current state of knowledge. I think it ended up at a certain point growing to 4.5 or 4.6. He retired, and it was 15 years later, just last fall, he had open heart surgery. He had a repair, no familial history or anything like that. He's doing great. I think he's kind of like an object lesson of how this nuanced approach can work. He told us, he said, if I had been a competitor from Italy, they would have just said no. So this shared decision-making stuff, I don't know, Dr. Churchill, how do we do this over the long haul with our patients?
It's a great question. And I think, that what you're getting at is an example where a lot has changed, but there's still a lot of heterogeneity by location around the world in the approach to these kind of things. And so I think really, as I think kind of echoing what Carmen had said, I think the best advice there really is to really find a physician to partner with who will sit down and understand your goals, understand your values, and understand what you're working for, and try to have that be a partnership that can continue over time. I often say I don't have any sort of secret sauce or special medicines that we give in our clinic, but I think what we have is a perspective of viewing the patient and trying to lead with the idea of understanding what's important to them. And it's not always what's important to me. And there's times when, and I'll certainly say, I think we should do this or that. It's not always like giving people just a menu of options and say, pick and choose. But I think leading with trying to understand their values is really important. And then I think the other thing to mention in line with Jack's question really is that the other way that we do this for the long haul is we get data, to build off of what Alan was just mentioning, that there are some areas of this where we have a lot more data than we did 20 years ago. That bicuspid, the return to exercise after surgery for bicuspid, there was a paper that Alan and colleagues wrote, and that was the first real data in that area. And it's not huge. We need more, we need longer, we need bigger, but these are, I think that is how we change the paradigm, and we can add greater nuance and greater rigor. I more than I can imagine, more than I like, I tell people, and I try to be very transparent. I say, this is a reasonable understanding. This is what I think, but we don't have the data for this. And so my hope is that over the course of my career, that sentence becomes a less frequent one in my clinic. And so I think that those are the ways that I think that partnership with the clinician, and then collectively working to try to expand the science and expand the data that we have, are the kind of the ways that I think this progresses over time.
Let me turn it over to Carmen, but just before that, if you're watching live and you have a question, type it into the comment section, and we'll get to some of those towards the end. Go ahead, Carmen.
Yeah, so kind of along lines with what you were just saying. So we know that these guidelines apply broadly to anybody participating in those competitive sports, from children to masters athletes. But what application do these have to, in our group, the non-athletes who have aortic disease, who may exercise more casually, or even those like Jack and I who want to do endurance events, that are kind of in the middle of those two groups?
This comes up all the this comes up in particular for our large population of people who have heritable thoracic disease, Marfan syndrome, Loeys Dietz, vascular EDS, things like that. And again, we encourage physical activity. Movement is key. So really, rather than say what you can't do, we say, what would you like to do? And let's start there. How can we incorporate low and moderate aerobic exercise, endurance exercise at a pace, again, where it's not at the highest level? When you do resistance training, how to do that, achieve the goal that you have without, muscle fatigue, where there could be changes in blood pressure and things like that. So as opposed to building muscle mass and becoming a bodybuilder or strength trained athlete, having great tone with a repetitive exercise and repetitive isometric exercise. So we always start with that, and to see, rather than say what you can't do, always, what would you like to do? How can we incorporate movement, physical activity, and recreational sports into your world? But again, there's every gradation of recreation you can imagine, from the recreational athlete that's really a fierce warrior, where she is really a competitor in the recreational field, as opposed to the competitive person that's at a snail's pace. So you can imagine that's just the word. So again, you really ask, what do you want to do and how do you want to do it? And let's work and see what we can do to make sense. And just as Tim said, this is a data-free zone. So to say that I know that there's going to be this risk or that risk if you do this, that's really just not possible. Really, the best we can do is give our best guesstimate. So we like to know what's your aortic health like, what's your blood pressure like. In some people, we put them on a treadmill, or we do activities where we try to recapture or recapitulate that activity, measure blood pressures and things like that. We did a study with Siddharth Prakash, who's probably been on this with you guys, and the group in Michigan. We looked at about 88 or so odd people with aortic dissection, many with underlying connective tissue conditions, put them through exercise protocol in a rehab facility, measured their blood pressure with all sorts of exercise, and then sent them home to do the same over the next year, and codifying, what's happened. And it's interesting watching some people on the treadmill where the blood pressure goes to 180 when they're not doing very much. You're like, oh my gosh, that you'd never have known that, who was hypertensive when they started, and others, it doesn't budge at all with the same level and same exertion. Others do a wall sit and the blood pressure's off the charts because they're deconditioned, and then they do it more and more. So we really want to work with people and really understand, what's possible and what will be best for you.
I was part of that study, and my problem's the opposite. Mine goes down, when I exercise, my blood pressure. But the changes from the last 5 years, so shared decision making, masters athletes. I think there's new stuff about cyclists and triathletes and some different areas like that. If you guys, Dr. Churchill, if you put on your visionary glasses, in 5 years, where would you like to see the next statement getting to?
Yeah, I think the goal will be that the next iteration of this will allow us to have, I think, really more data underpinning the recommendations that we have. And I think that's fundamentally a lot of what we included in here was really based on opinion. And I think that's part of the reason that this, one of the major distinctions between what we did as a scientific statement here and what are kind of in the cardiology community viewed as guidelines, and that guidelines will have what's called a level of evidence behind any recommendation. And in this case, the level of evidence would have been basically opinion or consensus. And so I think my goal is in the next iteration of these that we have, and it's not going to be everywhere, but that we have in at least a few areas, we can have some real quality, prospective condition. And the challenge with aortic disease is that it's so different between a Marfan patient and a bicuspid and an unexplained patient that we can't just do a study of 50 cyclists and with a big aorta. We have to have, we have to curate a group of the unexplained aortic dilation, Marfan's exercise and Marfan, all these different areas. And so I think that's the challenge in there, but that's sort of the impetus for us as a profession.
Do you think that the advancement of identifying the genes will make a difference in this, number one? And number two, everybody's talking about ChatGPT and AI and the advances. Is there any role for that to play in getting us the better data?
I think there will be new genes discovered. There'll be polymorphisms. There'll be multi-risk scores to try to predict, what happens to the aorta at different sizes to help us understand, when should somebody whose aorta is very large should have an intervention, because the risk of living without surgery is higher than the risk of surgery. So that's always something that we're interested in. I don't think that really answers the question that you're asking about, athletics and things like that. That's a different thing. I think what we know is that acute aortic events in people who know they have aortic sizes that aren't very big is pretty low. That's pretty well known. It's known now in the bicuspid. More people are exercising with bigger aortas in middle age with bicuspids because we're letting them. And aortic events are still very low. In genetic conditions, the whole aorta and other blood vessels are at risk. So it's just a different set of circumstances that's really unpredictable is the problem. It's going to be difficult to, and that's a challenge, because you could imagine a 7-footer with Marfan or something whose aorta is dilated, who wants to participate in the highest level because they're gifted, is a different risk to the whole situation. That's going to be difficult to answer that. I think social media groups, organizations, aorta athletes are incredibly enriched population, a cohort to say, because you say, well, how do you do a study of people who've chosen to do? I mean, if you have 25 Jack and Carmens in your group that are doing marathons after an aortic dissection, what's happened to you? Yeah, it's not randomized, it's not controlled, but it's reportable. And you say, okay, we know that in that choice, this is what's happened. And when the answer is favorable, that's so rewarding, because that's the sort of data what we need. Again, we're not going to say you can't do it and you can, and we'll see what happens. That would be a randomized trial. But in people who've chosen to do things, you take the best information you can, age, sex, family history, genetics, et cetera, and say what's happened. So at least you have some population. Right now, we don't have any data. So that's the challenge about giving. If no new data came in, the guideline statement would be the same in 5 years. It's just Tim would be 5 years older and might feel a little differently in 5 years than he does now. But really, you want to know is what did we learn? One of the biggest changes is how people with hypertrophic cardiomyopathy are managed. Now, defibrillators, AEDs on the sideline, participation is the norm as opposed to the exception for many people with that condition, where it was a complete restriction on the last ones. And that's because studies have shown that the risk is not higher with participation for certain individuals. And that's a game changer. Now, we don't have that sort of rescue in acute aortic syndromes, so that's a different thing. We don't have an AED for the aorta on the sidelines, but we do have, emerging data about risks at different aortic sizes. We have so much more information that says when the aorta for non-genetic conditions, sporadic, bicuspid, et cetera, between 4.5 and 5, carries a very small risk. The risk of an intervention is generally much higher than the risk of an event in that group living life. And between 5 and 5.5, there's equipoise, and you have to choose depending upon a lot of factors. But so I think, again, data-driven information, and I think your group would be a very, very nice way to look at that. You've done that in a survey, but I think that'd be a good way to do it in a very scientific way, at least observationally.
Yeah, I think, and just to add on briefly, I think to Jack's comment about the role for where will AI fit into this or other similar technologies? I think one thing that those technologies may offer to us is the ability to extract patterns or information or inference that is latent that we're not seeing. And so we've done this with the standard EKG, where we can build out computer models, and the EKG can tell you how old you are, what your heart's pumping strength is, whether it's a man or a woman. We develop a model for the EKG predicting fitness or the peak VO2. And so I don't think we're going to be deriving information on the aorta from the EKG, but I think there's the possibilities of either diagnostic or prognostic inference from other information that we're not necessarily appreciating. Is every 4.5 centimeter aorta the same? I would imagine that if you feed enough data into a computer, and this is more of a machine learning than an AI per se, but you feed enough data into the computer will often see patterns that even the smartest physicians don't necessarily see. So I think that's an area that people are already leveraging, and I think I would expect that we'll see more of over the coming years and decades.
Carmen, should we see if there's some questions?
Yeah, let's see what's out there. If anybody's tuned in, what's online in the chat.
Well, yeah, let's say hi to the chat. Starting at the top, hi Velda, hi Tom, hi Linda, hi LG, hi Ken, hi Greer. We do have a couple questions in here. Let's see. Is there a rate of growth in dilation that should cause a person to consider easing up on exercise?
Stability. How important is stability?
I'll take the first stab at that, Tim. So in general, the aorta grows very slowly. So in somebody without an underlying aortopathy, the aorta typically changes about 1 millimeter per decade of life. So it's a very slow change over a lifetime for the proximal aorta, for instance. And in those who have underlying conditions like Marfan, et cetera, the average rate of growth, again, is very slow. Not even a millimeter a year in patients randomized into trials we participated in for medicines to slow aortic growth. In treated patients, it grows a fraction of a millimeter in a year. So you have to do several years of measurement to see. The most common reason for a change in the size of the aorta is that two different people measured that same aorta differently, or the image was acquired differently, one by echo, one by CT or MR. The one was oblique as opposed to a double oblique, proper measurement. So when you do get a measurement that doesn't sound right, and I challenge everyone I encourage everyone listening to say, what's my aortic size? Was it done the same way? Did you look at it? Can you compare them side by side? And that was written, Tim wrote that into the document. That's super important because that's a source of tremendous anxiety, especially after a dissection when the measurements change. So you want to make sure that's careful. Now, rapid growth occurs in a very small number of people with aneurysm disease. Now, after a dissection, certain subgroups grow more rapidly. Untreated hypertension, smoking, ongoing, methamphetamine and cocaine, and then genetic aortic disease. So Marfan, Loeys-Dietz, vascular EDS. After a dissection, the aorta will grow more rapidly than after hypertensive or sporadic dissection, for instance. In general, 3 millimeters, so the variability of a measurement is 1 or 2 millimeters. Between Tim and I could look at the same study and we could be off by 1 or 2 millimeters between us, and that's the same ballpark. 3 millimeters is a rapid growth of the aorta. And by definition, 3 millimeters 2 years in a row would be rapid growth, or 5 millimeters in a year after a dissection distally or something like that. So it has to be a pretty substantial number. So if that was a real finding in somebody, you'd want to investigate why and what were the underlying reasons, et cetera. And if exercise, it's some sort of thing with exercise could potentially play a role, you'd have to understand, well, why would that be as opposed to anything else, and then come up with a plan.
As an award-winning answer there, Doctor.
Well, that's just what I think, but I think that's what it is, really. So Tim, anything, what do you think?
No, I mean, I would echo that. I think I would emphasize the point of that the most common reason for a big change is different people or different imaging studies. And I think when we look at when we do see change over time, and it's rare that we get to those thresholds of greater than 3 millimeters in multiple years, or 5 millimeters in a year. Those are the real minority. I think the more common scenario that you might see is a millimeter per year on a number of successive years or otherwise. And I think it's important for us to have a very broad view of what we think the underlying conditions. And in most cases, the framework that I often bring with people is that it's possible. I think it's sort of possible but unproven that the exercise may be potentially contributing, and we should consider that as a possibility in addition to all of the other things that we're doing. We should be meticulous about the blood pressure. We should be and really start thinking about a multi-dimensional approach to that, one of which is exercise. And that may be a scenario where we sort of talk about modifications of what people are doing, but it's not, I think, jumping to, in the vast majority of cases, jumping to say, oh, it's because the person runs for half an hour 4 times a week is erroneous in terms of placing the blame on the kind of missing the forest for the trees.
Yeah, I couldn't agree more. It is also important, since if many times someone has an image once a year, and the aorta may grow, and when it's compared side to side year after year, somebody may say, well, it's within a millimeter, so it hasn't changed. But just like watching your kids or watching a tree grow in your yard, if you haven't been there for a while, or let's say it's a grandchild, you're like, well, I haven't seen you in a while, you've really grown, because they have. So if you're looking at things every day, it doesn't change much, but it could be over 5 to 6 years, it's grown 4 or 5 millimeters, because it really has. And that's the natural history of the condition, not related, as Tim said, to what you're doing. People who exercise generally have better fitness, they feel better mentally, they feel better physically, their blood pressure is lower. We aim for 120/80 or less for the blood pressure. That's the goal in aortic disease. So we really try to get there through lifestyle, diet, exercise, movement, lots of movement, and then medicines as needed to get there. And 130/80 is not normal blood pressure when you have aortic disease. So those things are important.
Agreed.
Joshua?
I also liked both of those answers as well, which is a great segue for what Greer here says. For those in watch and wait with an unexplained aneurysm, why isn't moderate exercise simply recommended? Wouldn't being in better shape increase your odds of a successful surgery and recovery?
I think that's a great question. And yes, I think, just as Tim and others have wondered, it's possible that the aorta remodels in a favorable way to exercise. It's possible that the size of the aorta a bit bigger after endurance is Mother Nature's way in adapting, just like the size of the heart during endurance exercise may be different than those that are more sedentary. And maybe that adaptation does allow the person to deal with the aorta, to deal with the everyday stresses and strains of surges in blood pressure that come when, like, your computer screen breaks down in the middle of a talk about 2 minutes before you're supposed to go live with your favorite aortic athletes group, stuff like that. So in other words, it's preconditioning. So this exercise, I agree. I think moderate exercise is good for you. I wouldn't take it off the table unless there's a very special reason that says it's not that it's harmful. And we don't have that information for the vast majority. Some people do have hypertensive responses to exercise, so it is worthwhile exploring that, especially in those that are hypertensive at baseline.
And I'll add in the recent, less specifically focused on here, but in the recent aortic disease guidelines in general, there is a recommendation for people who are in this watch and wait zone to encourage what they labeled mild to moderate intensity aerobic activity. So that's actually in there, and if people's physicians are discouraging that, you could ask them about that.
I think Dr. Braverman had something to do with that, didn't you?
I believe so.
Well, we did two things, Jack and Tim, and you guys know this. Just because of that question, we wanted people to have movement and activity. And even importantly, for those who've gone through aneurysm surgery, dissection surgery, that didn't have valve disease, previously, cardiac rehab was not a benefit on insurance. We wrote specifically that cardiac rehab is necessary. We put it as a class 1 indication with no randomized data. That was really a consensus. As Tim said, but we got it in there. So we used that when I discussed with my friends who asked for pre-authorization for insurance coverage. And I just say, well, there's a nice document that actually says we're supposed to do that. So I want to make sure I'm following the standard of care. And then so this should be covered.
Joshua, let's do one or two more, then we'll wrap it up.
Okay. We do have some anonymous questions here. The first one here says, lower number in blood pressure tends to be high. Could this cause further dilation?
Is it just, go ahead, Tim.
No, so what the questioner is referring to is what we refer to as the diastolic blood pressure, which is the blood pressure when the heart is not actively contracting. So blood pressure is composed of two numbers, the systolic and the diastolic number blood pressure. And the blood pressure when the heart beats, the blood pressure surges, that's the higher number, the systolic. And the lower number is what is measured when the heart is not actively contracting. And I think I think both numbers are important for aortic health, and I think both numbers are things that we certainly pay attention to when we're thinking about optimizing the risk profile to try to prevent any disease progression, because you can imagine both are essentially causing degrees of strain on the aorta. So dissecting the relative contribution of one versus the other is not something that I think that we've sort of really known or been able to do. And I think both would be ones that we would think would be potentially important. And then when we take this, and I think dovetails very well with what the approach that Alan was mentioned there, which is that we really, when we treat someone with aortic disease of one kind or another, we want to really throw the kitchen sink and to try to make every feature as good as we can. So that includes both systolic and diastolic blood pressure in my mind. And any additions on that, Alan?
That's perfect.
Right on. So Dr. Churchill, you were one of the authors of a landmark study back in 2018 regarding masters endurance athletes and aortic dilation. It was to be followed by a long-term study with updated results. Can you tell us the status of the follow-up longitudinal study and when we might expect to see the results of the new phase of that study?
Wait a minute. I just want to ask, which aortic athletes data nerd asked that question? I probably could predict who it is. I don't know.
That's a great question. We've been working diligently on trying to get follow-up on as many individuals, which is has had some challenges posed by the fact that the original study was done with individuals from across the country. So we've been working on that and have actively enrolled a substantial, although aiming for more number. And I think the hope would be to have a readout on some level, which is not going to be perfect, but is going to be what we've been able to get in the next, I would say, the next year or two. And then I think the goal from there is really to transition towards an idea of looking at things and collecting data prospectively with an eye of collecting data and following people to really look for look for the implication, not only changes in aortic dimensions, but also the clinical implications of that. So both of those are kind of are in the works. If anybody's able to help take care of my kids and otherwise, I can probably get things done a little faster. But it's actively in process, and I'm hoping in the next kind of in the year or two timeframe to be able to at least have the results that we've been able to accrue. So thank you for thank you for reading that, and thanks for the question.
Well,
that came in anonymously.
Thank you. Yeah, and thank you guys both for participating with us tonight. You know, aortic athletes, I sometimes say would be an empty gong. We'd be an emotional support group without your participation in the guide and the statement, but more importantly, your willingness to come here and take what's really a very complex document and put it into terms that we can digest and bring back to our cardiologists and ask better questions and live a better life. So we are very grateful. We're indebted to both of you for being just exemplary members of your cardiology community. And so we're grateful.
Well, thank you. I know I'll speak for myself, but I think I'm sure Alan feels the same, that it's a real pleasure to be able to really connect directly with a community of afflicted patients and really try to share something that I think is really important to both of us.
Yeah, I agree. Jack, Carmen and Jack, and your whole community, thank you for what you're doing, bringing the group of people together where exercise and being physically active is so important to you, and not physically, but probably just mentally, because it is for all of us. And really what we're able to do and the way the guidelines change is in large part because of the strong motivation of this community. Say, we're going to push the limits because it's important to us, and that's how we learn, and that's what's going to move this forward. Is the sort of things that you guys are doing. We see it in all the different support groups in the genetic aortic world, and they would love to be more active with more data as well. So thanks for the invitation. Tim, congratulations on a really magnificent paper, and I know the next paper is going to come, and you know, I hope you could get a lot of support to continue the work that you're doing. It's really landmark. So congratulations, and glad to be your friend.
Thanks so much,
Carmen, do you want to take us out?
Sure. I was just going to say again, thank you guys. What you said there was so important because people really want to be able to do something and be active. And, all you aortic athletes have heard it here. This is important to them. They're working with us, and we should be able to hopefully do a new survey soon to not only help us with improving our outcomes, but to get publications out there and changes and guidelines in the future. So thank you for being here with us, and we'll let you guys know when the next session is with our wonderful experts or anyone new that we have coming. So thank you so much.
Thanks so much.
Good night.
Bye. Good guys.
Excellent work. Please don't hang up right away. Don't forget to like and subscribe. Don't forget to follow everybody. The social media links will be in the description below. Have a great night, everyone.